like you to help me welcome Dr. Lowell Anthony to the stage.
Thank you very much, Bob. It's a real pleasure to be here today. And one of the things I really want to emphasize is this is an informal opportunity for us to get to know each other. And what better to have that than in some tent outside of a hotel, right? So I think the ambiance of the meeting setting is just as important as the ambiance that we tear down the barriers that separate us from one another and the knowledge that we need to gain from each other. So one of the principles of things that when we start to talk about things that we're interested in, we disclose where some of the support comes from. And if you have no support, you're probably not doing anything. So we have a grant from the Markey Cancer Center, from Lexington Pharmaceuticals, from Novartis, from AbbVie Stemcentrx, to advance the care of neuroendocrine malignancy. Now, when we talk about controlling symptoms, we want to really know where is it coming from, how do we classify it, what are the choices. And I want to make this talk that simple for you. What exactly is one aspect of the enemy, because this enemy has got there's battles on multiple fronts. And today's front that I want to talk about is controlling symptoms in which the tumor is secreting products. So we have to recognize the enemy, classify the enemy, and in this case we think of it in terms of what the pathologist tells us is the grade. So what helps me a whole lot in working with people is to start with the pathology report and make sure we're all on the same page. What is the pathologist actually telling us with this piece of paper? One of the most confusing things that is to everyone, and it was confusing to me when I began this journey, gosh, it's been more than 3 decades. But I'll never forget stopping a pathologist at Vanderbilt in the hall and telling him how confused I was when we're classifying a cancer as a tumor. Why do we not just go ahead on the pathology report, call it what it is? And Dr. Robert Collins, never forget the man at all, he sort of looks at me, he says, Lowell, with tumors, some are benign and some are malignant. And what can you say when he says that to you? You're right. You're absolutely right. Some are benign and some are malignant. So we happen to be dealing with malignant neuroendocrine tumors that now we grade according to how fast they're growing. If it's grade 1, the pathologist will look at the high power fields. He'll potentially look at a stain that comes off a computer image, and they will quantify that, how many cells are actually dividing. If there's only 1 or 2% or so, grade 1. And we know when Dr. Orbendorfer in 1907 gave us this term, and this is the 110th year anniversary of this term given to us in the medical literature. Being a German pathologist, the term was carcinoid. And what he meant to convey with that is something that had a good prognosis. This is not cancer. It's like cancer, and that's kind of the way it translates to us. So the most important thing that we see, what is the grade? Grade 1, is it grade 2? Now, just in the last 5 years, the grading system now recognizes it's a small group, probably 2%, but it's a group that we need to recognize up front, not get it confused with the other groups. It's grade 3. It's well-differentiated grade 3. Historically, we would look at this and say, oh, that's the same as poorly differentiated neuroendocrine carcinoma. and just treat it as such. But no, it's not. If the pathologist says we have a well-differentiated tumor and the mitotic index is greater than 20%, or the Ki-67 index is greater than 20%, we need to consider another form of therapy. Just consider it. We were still working in this area. We don't have everything organized at this point. So where do these cells arise? The neuroendocrine tumor, these cells are ubiquitous throughout the body. But they're concentrated in certain areas. They're concentrated in the pituitary gland. In the pituitary gland, they're adenomas. So fortunately, in the oncology world, we don't see that. They're not malignant for 99.9% of them. They're concentrated in the thyroid. There's medullary carcinoma of the thyroid that we see. It's uncommon, but it exists. Lung, bronchial, comprises about 25% of the neuroendocrine tumors. GI, pancreas, are the other ones that we know and can predict pretty much the biologic behavior. When we see these tumors, there are certain characteristics that when we see it, it all comes together and we know that what we're dealing with. These tumors are highly vascular. These tumors have a fibrotic or a desmoplastic reaction. We can see this on the scan. We can see this on the pathology report. So when all this adds up, and in this case, the tumor here is circled, it translates into potentially carcinoid syndrome. So carcinoid syndrome will occur when, more likely than not, there's disease in the liver. What the syndrome comprises of is flushing. Flushing is typical dry flush. It's typical upper body, face, neck, upper chest, sometimes hands and the soles of the feet. About maybe 10% or so people may have reactive airways. And Dr. Coles actually published a paper from the Mayo Clinic when he was here, seeing a patient with bronchial asthma and seeing that when you treat that, just like a carcinoid syndrome, the breathing improved. Pulmonary and tricuspid valvular disease. This is related to what serotonin what the tumor is making, the degree of exposure to serotonin. Now, it may not be serotonin causing all the damage, but it's a marker warning us that the damage is occurring. Hyperperistalsis and diarrhea. We're going to talk more about this, or the mechanisms of why this occurs. But basically, the gut is in high gear, is what that basically translates into. On scans, we see disease in the liver. We can see the primary tumor in the bowel or in the pancreas or in the lung. We can measure the products that this tumor is secreting. We can measure a glycoprotein called chromogranin A. It's not specific, but it's sensitive. It also has false positives with PPIs, proton pump inhibitors, drugs that we take for GERD symptoms. If this tumor produces serotonin, the serotonin gets metabolized to 5-hydroxyandoacetic acid. We can measure the byproduct in the blood. We can also measure it in the urine. Historically, it's been a urinary 24-hour collection. So this is just the anatomy. The tumors live, when they metastasize, they're metastasizing from the gut. And so if a tumor is shown here, why is it that we see so many liver metastases? And because of that is due to the blood flow, the splanchnic blood flow that's shown here. The tumor cells break off, and the liver is the organ that captures, traps the cells, and the liver provides an environment that the tumors can flourish. Is it possible to have carcinoid syndrome without liver metastases? Yes. Certain primary tumors escape this circulation. Tumors that arise in the lung, tumors that arise in the gonadal organ, testes, or the ovaries, have a different blood supply. We think of them as more systemic secretion, they bypass the portal system. So you don't necessarily have to have metastatic disease, but generally there is metastatic disease. Okay, so now I've told you a little bit about the enemy. Now we can jump right into what can we do about it. Historically, it's surgery, surgery, surgery. Why? Because that's the chance to cure. But the problem with this disease is people have had symptoms for years. By the time they're correctly diagnosed, surgery is not a curative option. It's a palliative option. Control primary. We can use it to debulk. And by doing this, we can certainly improve symptom control. Standard chemotherapy. When we look at the history of cancer treatment, that all starts with chemotherapy that came out of World War II, comes through the 1950s into the 1960s. By the time we get into the early 80s, it's streptozotocin for this disease. And this is what actually is approved today, this drug right here. Got approved in about 1982. And guess what? No, very, very few people use that as a treatment for this. But it is, when you look it up, it does have an approval process because of data that was gathered in the 1970s, mostly cooperative NCI, cooperative group type studies documented the value. But it's pretty much for grade 2. For grade 1, we don't associate a chemo regimen for tumors that just don't divide. And that's one of the mechanisms of why chemo drugs are indicated, is targeting those dividing cells. Dr. Coles worked with Jonathan Strasberg at Moffitt, and we owe it to them, this regimen of capecitabine, temozolomide, we call it CAPE-TEM, for grade 2 neuroendocrine tumors. And these tumors that they studied and reported on in the journal Cancer about 6 years ago had a significant response rate. It's probably about 70%. This was revolutionary in our world of cytotoxic chemotherapy for neuroendocrine tumors. The value in the grade 1 is yet to be established, so we look at it for Ki-67 index greater than 2%. So that would not only be pancreatic, but possibly lung and other primary sites. For grade 3, we're still debating what that regimen is. There's actually a study coming out of Case Western, that's cooperative group, that's looking at, do we use CAPE-TEM or do we use chemo? And that regimen, I wish them a lot of luck in getting that established. So when we talk about cancer treatments, we got to put the big 3 up there: surgery, chemotherapy, and radiation. Radiation, historically, we think of external beam. We think of, in the old days, of cobalt, and that's where it burnt everybody's chest, it burnt their skin wherever it was pointed. But getting out of cobalt, we have linear accelerators. We can focus the beam on certain tumors, and we know that for symptomatic bone metastases, that external beam radiotherapy can improve quality of life. However, a topic today is peptide receptor radiotherapy, something totally different. It's more like I-131 that we use to treat thyroid cancer, something that's been in medical use for 60 years now. So something that is not foreign. So in the world of radiation, we think of where the source of radiation comes from. Is it an open source, like I-131, or is it a closed source, like a linear accelerator? So PRRT, or peptide receptor radiotherapy, will be injectable. It's every 2 months, 4 doses. We'll talk more about that. Interventional radiology procedures, another opportunity as medical field develop very sophisticated catheters. Just like they do in cardiac cases, we can take catheters and put the tips of them in subsegments of the liver where the tumor lives. This tumor has a dependence more on the arterial blood supply than the low pressure venous blood. We can take advantage of that by injecting agents that slow the flow. So we can produce an anoxic condition for about 24 hours and cause significant necrosis when surgery and other opportunities are not, other treatment opportunities may be more limited. Those are typically called embolization procedures. They could be a bland, where we just do a vascular slowing agent. It could be with chemo, and there's a study going right now from the University of Pennsylvania that's looking at different options of randomization of whether bland or chemoembolization or TACE or chemo beads is to be. And then we can use Y90, which is a radioembolization. And then radio frequency ablation is not radiation, but this is just where microwave energy or high energy is concentrated through a special probe to necrose what's enclosed in that probe. Okay, so now we sort of move into the world of targeted therapies. Targeted therapy started with octreotide, lanreotide, or somatostatin analogs. We just call those, like we do PPIs for all those GERD drugs, we call these SSAs. So anytime you hear the word SSA, somatostatin analog, it means octreotide or lanreotide. So the somatostatin analogs work by binding to their receptor. The receptor is overexpressed on tumor cells. When that interaction occurs, the secretions are reduced, are inhibited. The synthesis of those products are not. They just aren't released. We use these drugs to not only control symptoms, but we also, it's been shown in multiple trials, to slow progression. Other forms of targeted therapy, the metabolic pathway that's termed mTOR, or mammalian target of rapamycin. We can take advantage of blocking this metabolic pathway with everolimus, also known as Afinitor. This drug came to us through the kidney cancer world early, got approval, and then in 2011 got approved for pancreatic neuroendocrine tumors, and then in 2016 was approved for grade 1 and 2 neuroendocrine tumors of the gut. And technically, the approval was non-secretory. Tyrosine kinase inhibitors, another term, TKIs. This is a group of drug, and there's one approved called sunitinib or Sutent. We think of these drugs as, this class particularly, as more anti-VEGF. VEGF stands for vascular endothelial growth factor. So it's working on the blood vessel, and we discussed in the very opening slide that these are hypervascular tumors. It makes sense for us to target blood vessels in controlling this disease. Tryptophan hydroxylase inhibitors, since February of this year, this has joined the armamentarium of ways we can go about to control symptoms. The way the approval, the way the study was done, the approval is in conjunction with the somatostatin analogs. So why do we need another drug to suppress serotonin in this case? Well, the need here is the fact that when we use the SSAs, we can lower the serotonin by so much, but we may not get it low enough to prevent carcinoid heart disease, fibrosis, and other aspects of the disease that we're very much tuned into wanting to prevent. So it gives us another option of lowering the serotonin, controlling symptoms, proving outcomes, and the story for this is really yet to be told. It's going to be, I think, a big story. It's going to come out in small pieces. So when we look at serotonin, let's just sort of look at the normal pathophysiology of what does serotonin do in the gut. Serotonin is a neurotransmitter. It acts as a communicator between cells. In the resting state, you can see here we have the neuroendocrine cells, in this case the Eckel cells, and the enterochromaffin-like cells is what they're called. And they're scattered in the epithelial lining of the gut. In the resting state, the serotonin just sits in the cell. The transporter for serotonin are in some of the adjacent epithelial cells. When there's a stimuli that comes along, there's release of the serotonin, and the serotonin transporters then kick into action. The neural pathways are activated, and we go into a stimulated condition. When you have carcinoid and you have serotonin produced all the time, not in the physiologic setting, but now in the pathologic setting, you can see having the intestinal tract in high gear all the time is not compatible really with a high quality of life, because we create what's called secretory diarrhea. That's a very, very important term, because when we have people who have had their bowels operated on, the short gut, the loss of the ileocecal valve, and bacterial overgrowth that can occur because of the loss of that valve, we put people on the SSAs that cause fat release, fat malabsorption, or steatorrhea. When we deal with diarrhea in the carcinoid setting, we have to ferret it out. Is it from the disease? Is it from the previous surgeries? Is it from some other condition? Or is it truly secretory? Is it truly related to the carcinoid disease? And the simple question that we can ask is it watery or not? If the diarrhea is watery, that's going to be something we need to work on. The body should not release water if things are working right. Should not be water in the stool. So that brings us up to serotonin metabolism. Serotonin is synthesized in normal cells, and in this case I'm going to use carcinoid tumor cells. It takes the amino acid from our diet, tryptophan, and tryptophan, as you probably have heard, it's the sort of the sleep product. It's you eat a big turkey dinner and you go to sleep, tryptophan gets blamed or the turkey gets blamed. It's not the turkey. It really is not the turkey. It's really how much you eat and and other things that do it, but tryptophan gets all the credit. So tryptophan gets converted to 5-hydroxytryptophan by a specific enzyme that tryptophan hydroxylase can inhibit. The serotonin, then 5-hydroxytryptophan then gets secreted, gets converted to 5-hydroxytryptamine, which is serotonin. All this chemistry was worked out in the 1950s. This is not something that just come out recently. And out of that work that was done in the 1950s, by about the mid-1960s, it was pretty obvious to investigators, hey, why don't we shut down serotonin metabolism synthesis and maybe we can improve the conditions of people. So by 1968, there was reports that were coming through the medical literature of a 5-hydroxytryptophan, 5-hydroxytryptase inhibitor. And this is a drug, chlorphenylalanine, that was too toxic. It got into the brain, the blood-brain barrier did not prevent its uptake, and we ended up having unacceptable side effects. So this whole science sort of came to rest after chlorphenylalanine was not an option. It did what it's supposed to do, but toxicity ruled. We now have a drug, telotrestat, that is an oral inhibitor that inhibits the enzyme that is the rate-limiting enzyme. So I'll show you the data that results from that, from 2 early clinical trials that demonstrated the favorable safety profile, and then it went on into showing safety that I'll share with you. In medicine, we base our decisions on evidence. The evidence for the use of telotrestat that resulted in its approval by the FDA in February was published in the Journal of Clinical Oncology, which is the publication of the Organization of American Society of Clinical Oncology. And this is a peer-reviewed journal, and I can say that it's had the utmost scrutiny when it comes about for the medical community to embrace. So this study, and we had about 12 subjects at UK that participated in this study. And the difficulty in proving things is the need for a placebo arm. Fortunately, this placebo arm only lasted for 3 months. Fortunately, people had the opportunity of more likely getting the drug since it was not an even chance of landing on the placebo. So nobody wants to be on this arm, but if you have a 2/3 chance of getting the active drug, that at least sounds promising. In this case, for this 90 days, nobody knew what they were on. They didn't know what dose. They didn't know whether they were receiving the drug, active drug or not. So after a 3 or 4 week run-in where a diary would qualify people and went through 90 days, then they would go on to an extension trial. And so people who we looked at, we attempted to get a uniform population of people, sort of trying to compare apples to apples. So it all had to be well differentiated. Most of this is going to be grade 1. It's going to be documented carcinoid syndrome with 4 or more bowel movements a day, currently on a stable dose of an SSA, and the dosing is shown here, and the higher dose and frequency was allowed as long as it didn't change during those 90 days. People couldn't go above 12 and qualify for this study, and they had to have other causes of diarrhea already addressed. The statistical design, the primary endpoint here is a change from the baseline in the daily stool frequency. That's a pretty interesting baseline in medical oncology. This is a supportive care baseline. This is not treating the cancer. This is treating the symptoms. And because of that, there were a number of institutions around the United States that would not open this trial because it wasn't a therapeutic against the cancer. I found that to be very interesting. Cedars-Sinai in LA was one of the top, where they have a lot of these patients. They would not open this trial. Too many other protocols where we're treating cancer to compete with. And we don't need to bother ourselves with supportive care trials. And so the baseline characteristics of 45 people in each group are shown here. And it was pretty evenly distributed. People were in the early 60s. Male were about 46 to 55%. Stool frequency was around 6 in each arm. The analogs are on about 2/3 to 3/4 on octreotide LAR. The lanreotide had sort of, while this trial was being developed, was being approved, and it got an indication while this trial was in process. So that would represent the differences here. Above dosing, above the standard dosing, about 40–45% above the 30 milligrams or the 120 milligrams of lanreotide given monthly. The 5-HIA, again, was balanced. And this is basically the data that we're looking at. When you're on placebo, your stool frequency would be on this line. If you're on either the 250 of tlotrostat, it's the blue line. And if you're on the green, it's the 500. So because of these differences, when the FDA looked at it, they approved the 250 3 times a day dose. They said there's really no difference between that, and we'll approve the lower dose. And this, in terms of reduction across the 12 months, you can see it just a different way of showing you a bar graph where placebo had about a 17% reduction. And when you talk to GI doctors who study this endpoint a lot, they say this is about right. If you give somebody a substance and tell them it's going to help them, about 1 out of 5 will report an improvement. So here we're up to around 30–35%. And then when we look at a durable response, and this was defined as a greater than 30% reduction for at least half the people during that 90-day blinded period. And so the durable response seemed to indicate that the drug was active. And then what happened to the 5-HIA? And this is what we found to be really interesting, is we saw a good reduction at the 250, but look at this. This is what the drug is supposed to do, and it did it in a dose-response manner. So we were very pleased to see that as we go up on the dose, we get a better protection of inhibition of serotonin. Now, this is what's called a waterfall plot, so that every patient who is enrolled in the trial, the results of every patient is shown here. So here, the lower dose, the placebo, you can see the gray areas. You can see most of the placebo groups are going to be above 0 in its inhibition of 5-HIA. And as we move into the blue and the green, you see an inhibition. A couple of these do go the wrong way. And in medicine, it's these outliers that we really get interested in to try to figure out what went on. We know that 5-HIA, the whole process, it can be a little difficult. This is the urine, collecting the urine, doing all the things that takes place with that. Has to be done carefully. And we always want to repeat it and study it and things. And this company went on and actually did it in the blood as well. And those data are not seen yet, but having looked at some of that, the blood levels show the same type of benefit. So when we talk about carcinoid syndrome, we also think about the flushing, we think about the abdominal pain. These were not the primary endpoint. So there was some reduction, but it's not a reduction that we can sit and brag about. It didn't meet statistical significance, so we don't really say that if your symptoms, we don't promise you or say that this is the treatment to control flushing that has a different mechanism potentially than the diarrheal mechanism. This is really pretty astounding in terms of from a safety perspective. I talked to you earlier about chlorophenylalanine as being too toxic, and the toxicity was more CNS. Now we're doing the same kind of thing. We're blocking serotonin secretion, and we're not causing people depression and sleep disturbance and psychiatric problems that everyone is very concerned about when you start perturbing serotonin chemistry in the brain. Well, nature has really given us two enzymes of the tryptophan hydroxylase, and we call those enzymes isoforms. So with this one, there's one isoform that is in the intestinal tract. The other isoform is in the blood-brain barrier. So when we're inhibiting serotonin, we are not inhibiting serotonin in the brain. We're inhibiting serotonin in the peripheral, in the body, everything except the brain. So 90% of the serotonin is going to be sitting in the gut. 90% of extra CNS serotonin is going to be gut-based. And that's where we've been able to block the synthesis of and translate that into a mechanism to control symptoms. So as we went through this, the safety of it was astounding. We didn't have people with the kind of side effects that we were all looking for. What was some of the things we saw? Constipation. Constipation. There's actually a death on the trial from perforation of the intestinal tract from constipation. Now, was that from the drug? Or was that from the person's underlying disease? Or how, that's a difficult safety feature for the company that went up for the FDA. They don't want this drug associated with bowel perforations because it really doesn't cause bowel perforations in the nature that you would think that if it was a real problem. So if you look at the serious adverse events, and these numbers here is what everyone focuses on in terms of, is there a black box warning? How much education do you have to provide for practitioners who can prescribe it? So 2% on the placebo experienced a treatment-associated adverse event that was considered serious, a grade 3 or grade 4. And on the low dose, 0 of talotrostat. And on the higher dose, 4.4%, one extra person had it. Of interest, about the nausea was a little bit more in the higher dose, 29% versus 13. The placebo had 11%. Depressed mood, these are the things that we were really focused on. And having this as a higher percent here certainly did get everyone's attention. The depressed mood or the depression here in 3 patients on placebo sort of shows you that the suggestion that you could get depressed could result in you reporting it. On the lower dose, and this again is maybe why the FDA approved this, the incidence of depression was actually less than placebo. So the conclusions of the talotrostat study is that we can significantly reduce bowel movement frequency when we treat people with carcinoid syndrome and the SSAs. It's a durable response in 45% of the patients. We have a favorable safety profile. We can significantly reduce the 5-HIA, and we now have a new treatment with a different, unique mechanism. So the meeting, what I really want to get across in this talk is not only the serotonin story, but also all the other things that we do to control symptoms. We have surgery, we have cytotoxic chemotherapy, we have radiation, we have interventional radiology, we have our targeted therapies. What's the future? And this is really what it's all about. It's not what you did for me yesterday, is it? It's going to be what are you doing for me today, and what can you do for me tomorrow? So the future is what gets us excited. And we've got a talk at 11 that's going to focus on our research projects. But I've kind of outlined here some things that you're going to hear about as we go down the path of what's coming down the not too distant future. Combinatorial approaches. We know that when we get a new drug, whether it's an SSA or an mTOR inhibitor or a VEGF inhibitor, we know that these approaches are not curative. PRRT is not going to be curative. We know we need to do something better with that standard of care, that new standard of care. So we've been handed everolimus or Afinitor in the neuroendocrine world about 6 years ago. What can we do with it? What's the mechanism? How can we make it better? We have an approval. People can get this paid for. We know the toxicity. And so we've worked with a company that has a vascular disrupting agent. And so marrying what is basically a medical embolization. I talked to you about a radiologic embolization, but a medical embolization is where we give a vascular disrupting agent in the vein. This agent comes to us from the bark of the South African willow tree. The NCI discovered it in their natural products screen. It's been with the medical community for, probably about 15 years. The company that's promoting this has as their primary target ovarian cancer, and that's where their registration trial is. We've been studying it here for about 3 years. We've seen some very nice responses. It's not curative, but we think for some people it can control their disease. And our question is, if we combine it with a standard form of treatment, can we improve the outcomes and at the same time not cause added symptoms of treatment? PRRT, how can we make that better? Well, in external beam radiation, we've worked very deliberately and passionately on improving responses with what are called radiation sensitizers. Will that work? Will that same approach that we've done for external beam, will that work for the open source for lutetium-177? Every time you turn your TV on now, you see advertisements for immune drugs. These drugs that you're looking at, we call them CPIs, or immune checkpoint inhibitors. So there's two now that are out there. Melanoma has kind of pushed this area. We've known for years that melanoma has an immunologic approach that it's not surprising to us that taking stage 4 melanoma from 1 year out to 3 or 4 years was not surprising, that it would be the immune-based and not chemotherapy-based. And then drugs used in combination with the immune checkpoint inhibitors, the cytotoxic T lymphocyte associated protein 4. So this work is really coming to us from the melanoma world. And in this world of neuroendocrine tumors, we have a study looking at these checkpoint inhibitors. We're in the process of opening it. It's opened already in a few centers, of looking at a monoclonal antibody that is given every month to suppress the suppressor that's keeping the immune system at bay. From our early work, it looks like the higher grade, maybe grade 2, grade 3, poorly differentiated neuroendocrine carcinoma that it's going to be that group more so than the neuroendocrine tumor grade 1 that may have that benefit. But we're asking that question of whether the grade 1s will respond. We won't have an answer for that probably for about 18 to 24 months. So when we start thinking about mTOR inhibitors, there's new molecules out there that block the mTOR pathway in multiple mechanisms, and there's a study going on. It's a cooperative group of this drug here, a dual TORC inhibitor. In Sweden, there's a viral approach that's an oncolytic virus. If viruses can kill normal cells, can you target them to kill cancer cells? I listened to Dr. Oberg give an update of this about 2 months ago, and it's struggling. You know, they've treated some people, but as any new form of therapy, there's always issues that don't just translate into an easy pathway. So I get asked quite a bit about the oncolytic virus story. You can go on the web. You can look at their what information they have from Uppsala. And then the antibody drug conjugates, and this is what we're interested in, where we take a drug, make an antibody to a certain protein or receptor, and then put a conjugate with it. This is an area where breast cancer has led the world, and we're doing something similar in the neuroendocrine world with a drug called rovalpatuzumab that tesserate that we're using in higher grade tumors. We're not doing that in grade 1 as much unless the protein DLL3 is expressed, and that's expressed usually in more higher grade tumors. And then there's a study, the PIN 221, when you get on clinicaltrials.gov. This is an exciting study, not open at our center, but is a study that's very similar to our DLL3 rovalpatuzumab study, but now instead of using the Notch protein DLL3, they're using the somatostatin receptor. So I think of the PIN 221 drug as basically PRRT without the radiation. Same concept, target the somatostatin receptor. Instead of delivering the payload of radiation, you deliver a payload of an agent that is already being used in a similar manner in breast cancer, so we know a lot about the side effects.